Good morning, good afternoon, and good evening from wherever you are joining us from. My name is Aisha Kokar, Associate on the Boost team. On behalf of Boost, a warm welcome to our Bright Spot series, co-hosted with Solina Center for International Development and Research based in Nigeria. This is the final session of our three-part series, Northern Nigeria State's Routine Immunization Strengthening Program, utilizing community resources to drive demand for immunization and primary healthcare services. Next slide. Sorry, next slide, please. Thanks. During this session, we hope to disseminate and showcase learning from the utilization of community resources to drive demand for routine immunization and primary healthcare services. We hope by the end of the session, you will gain an understanding of SCIDaR's innovative journey of community engagement strategies implemented across MOU states in Nigeria and gain knowledge of the successes and challenges of each strategy, emphasizing lessons learned. Next slide. Now would be a great time to please introduce yourself and your name and where you're joining us from in the chat. Before we get started, I'd like to go over a few housekeeping slides. Next slide. During today's session, you will hear from our two presenters on the significance of demand generation for immunization uptake. Afterwards, we'll break into a panel discussion with our guest speakers to discuss demand generation in their own context and have time for Q&A at the end. Next slide. During today's session, please stay muted to limit background noise. If you'd like to speak, you can always raise your hand or put your questions or thoughts in the chat. Next slide. I'm sorry, next slide. Thanks. Please also note, Boost does not permit the use of artificial intelligence tools during our webinars or course sessions. Today's session will be recorded and slides will also be available by the end of the week on our Bright Spots Boost Learning group, as well as emailed to you with the email you used to register for the session. If you're able to attend all 3 sessions of this series and fill out all post-session surveys, you'll be awarded a certificate of attendance by Boost and SCIDaR. Finally, this series is only offered in English, but we hope to have more multilingual content soon. Next slide. For those of us who are joining for the first time, the Boost community is a diverse network of more than 4,500 immunization professionals from 156 countries. Through our online platform, boostcommunity.org, we offer opportunities to our community to connect with fellow immunization peers and experts, learn skills that build capacity and advance careers, and lead immunization programs in any circumstance by sharing best practices and lessons learned through sessions like these. To access today's recording and slides, we encourage you to sign up for the Boost platform and join the Boost Bright Spots Learning group. Next slide. For those that are new to the Bright Spot series, Bright Spots are stories that shed a light on the work that is happening on the ground and inspire immunization professionals to learn, adapt, and take action in their own communities. From engaging with religious leaders to improving supply chain to reach the last mile, there is innovation occurring at all levels of the system. To date, we have published more than 60 Bright Spots from 27 countries, which you can check out at the brightspots.boostcommunity.org. Next slide. I'd like to also introduce everyone to the SCIDaR team who have been co-hosting this series with us and thank them for supporting this 3-part series. Next slide. I'd also like to welcome our guest speakers who you'll hear from not only during the presentations, but during our panel discussion where they will share demand generation in their own contexts. Next slide. I'd like to welcome our first speaker, Dr. Ladan, to tell us more about the challenges with immunization uptake in Nigeria and involving strategies.
Okay, thank you very much, Aisha. Thank you very much, all of you on this webinar. My name is Dr. Aliu Adan, the Acting Director, Department of Advocacy and Communication, National Primary Healthcare Development Agency. So I'll be speaking briefly on challenges of immunization offtake, looking at both supply side and demand side challenges of immunization offtake in the country. So looking at the proportion of issues that are attributed with supply and demand side, for supply side, it's contributing to about 18%, with reasons like vaccinator absent, vaccines not available at the time of client visits to the facility, or the health facility is also very, very far away for accessing services. So looking at the demand side, which contributes to the chunk, about 82%. There are reasons like no need for vaccination. Most of the parent and caregivers do not consider vaccination as something very important that they will need and look for it. And there's also a fear of adverse event following immunization, because most of the service providers could not take time due to their poor interpersonal communication skill, cannot take time to really explain to the caregivers that adverse event following immunization, especially minor ones, are temporary and very normal. And there's also issue of consent by husband and relatives who may express outright refusal for a mother to take the kids for immunization. So looking at the comparison between 23 coverage in across two different sections of the country, the north and south. For the north, the coverage is very, very low, for 27%, than in southern Nigeria, which is 69 to 86%. And we can also say low immunization coverage in northern Nigeria, especially as we witness in the CSMOU states, can be attributed to poor economic status of most families in the north. And at the community level, there's also issue of poor community participation and involvement in designing their health programs. And there are also other socio-cultural barriers at both interpersonal level, at socio-cultural level, which are also contributing to demand side issue on poor demand for vaccination. Next slide. Yeah, so we are all witness to the fact that over the years, there are a lot of investment in the country, especially in the CSMOU state, where a lot of effort has been put in place to implement demand side intervention that will also contribute to creating demand for immunization and by extension of the PHC services. This includes the volunteer community mobilizers. We all know them, how they play significant role. Polio, and there is also the National Adapted Community Engagement Strategy, particularly the name-based community engagement strategy, which we started implementing in the CSMOU states, using the traditional leaders as the pivotal resources for the implementation of the name-based community engagement strategy. There's also the CHIPS program by MPSCD, which is also all aimed towards creating demand for immunization and other PHC services. But not that, upon all that investment, that has not contributed to what we desire to see ourselves in terms of assessing immunization services and other PHC services, especially by the underserved communities. Next. So we are very confident that there are key components for successful demand generation strategy, as we see examples in some low middle income countries, like the integrated community workforce, the comprehensive demand generation strategy. For instance, in Indonesia, we saw how the community health volunteers the cadres system contributed to bringing coverage to an appreciable level. In Bangladesh, there are also community health volunteers, which is called Taya Shebeka, which is a trained volunteer program that usually conduct house-to-house sensitization, something similar to what the BCMs are doing for polio and also what the chiefs are intended to do. And in countries like Ethiopia, there is also a women development army, which is a network of community women home to provide first-hand information to mothers on the importance of immunization and other PHC services. So implementation of these key components of successful demand generation strategy, notably integrated community workforce and the comprehensive demand generation strategy, will support the linkage between communities and the health system, which may eventually lead to uptake of immunization services and other PHC services. So this is where I come to the end of this short presentation, and I'll pause here for comments and other questions as related to the presentation. So thank you and over. Aisha, over to you.
Yeah, we can hand it over to Sophia, our next speaker.
Okay, sorry. There was a problem with my mute button. So thank you, Dr. Ladan, for taking us through the challenges with immunization uptake in Nigeria and the evolving national strategies. Good afternoon, everyone. I will be speaking about the evolution of demand generation interventions in the MOU states. The RI MOU was a partnership between state governments, BMGF, ADF in 6 northern Nigerian states. As the state moved from RI to PHC MOU, we had more donors supporting the implementation of PHC program in these states. Through these MOU funds, we have implemented a number of demand generation interventions. And we'll be discussing 3 specific interventions. That's the name-based strategy, the routine immunization body system project, and the Crown initiative. The name-based strategy was a key intervention that involved the collaboration between traditional systems as well as healthcare systems at the community level. And the purpose was to advance health and program performance within the communities. Traditional leaders were the lead on this strategy and with support from healthcare workers across all levels. Having an understanding of the challenges with the name-based strategy, we piloted the routine immunization body system project in Kaduna. The acronym for this project is RIPS. Caregivers within communities were formed social groups to eliminate barriers that hindered them from accessing routine immunization services, also, and thereby improving vaccination uptake. Key activities included promotion of RI services via advocacy, mobilization, as well as economic empowerment interventions. And then for Crown, just merging strengths from the various interventions and various strategies, Crown emerged. That's the Community Reorientation Women Network, which is a network of women across communities in northern Nigeria, promoting demand for key family services. They are also positioned as a grassroots social enterprise for literacy as well as female empowerment. We see these 3 interventions are iterative, with each of them building upon the findings and lessons learned from the intervention that came before it. On the next slide, is the name-based strategy, which we've implemented across 7 northern states. That's what we see on the map to the right, in the darker shade regions. And it was built on some key ideas. One issue we faced was not having the line list of children eligible for vaccination. Here we believe that traditional leaders in the North are skilled at gathering community information and are likely capable of collecting need-based data for immunization. So to address this, what we did was develop and disseminate a line list register to collect data relevant for immunization. We also lack the system for tracking unvaccinated children and believe that traditional leaders who we know are people that are respected across communities hold mobilized households and follow up with defaulters to ensure vaccination. Another problem we had, another issue was the lack of a link between community data and PHCs. We also hypothesized here that health facilities are the ideal location for health workers as well as community leaders to meet and reconcile the line list with the vaccination uptake data. For this, we institutionalized reconciliation meetings to enable them to collaborate with health workers and identify defaulters, just leveraging on their influence to make referrals. And finally, is the problem of sustainable funding for intervention. We believe that traditional leaders see their support. Okay. So we see that traditional leaders see their support to communities as a mandate. They also wouldn't require special stipends. That was what we hypothesized. So we implemented the intervention based on volunteerism. On the next slide, the implementation of the name-based strategy involved 4 activities, one of which is developing and updating the line lists. The Meongwa and health worker identify and document a list of eligible children for vaccination. That's what happens here. The other activity is the reconciliation of data with PHCs. This task was done by the community engagement focal person who works with in collaboration with the health worker as well as the Meongwa to compare and reconcile line lists at the facility immunization register. Then there was tracking of defaulters, and with the support of healthcare workers, Masu Ungwas were able to track defaulters or people that were left out of vaccination. And the last key activity is referral and linking to PHCs. Here, Masu Ungwas, with support from community members, referred identified children for RI session at the specific locations. What we see to the right is some survey results. 97% of RI service providers and 98% of Masu Ungwa believe that the name-based strategy was effective. We also see results for some impact analysis, and for all of the 6 MOU states, we see an overall improvement in pentatric coverage between the baseline at 2017 and the end line at 2021. On the next slide, addressing the challenges faced by the name-based strategy led to the pilot of the routine immunization body system in Kaduna State. One of the major challenges was the difficulty was that Meongwas were frequently occupied and unable to mobilize eligible children to health facilities. Another challenge was Meongwas also faced some issues in effectively mobilizing households where male visitors were restricted, also in elite communities where their status was not as esteemed. Another challenge was the absence of incentives, which limited the support provided by the Masongwas in carrying out their assigned activities under the name-based strategy. To address these challenges, routine immunization body system was introduced with key components. Community women, we don't frequently engage with each other, even during work, making them ideal for mobilization efforts. So it's recognizing this. It eliminates the need for separate mobilization activity. These women are then utilized, understanding that they are primary caregivers themselves and they are more acceptable medium for initiating discussions related to maternal and child health matters. And also is the, additionally is the introduction of an incentivized model, which encouraged more active participation and commitment from community women in implementing this strategy. So the name-based strategy, challenges from that strategy informed the design for the RIPS project. So RIPS was designed to remove barriers that prevent mothers from seeking immunization services using women collectives. So these women collectives are the body groups. And it was piloted in 2 LGAs in Kaduna. The strategy involved implementing key interventions to achieve its objectives. One of such intervention is the peer knowledge sharing intervention, which involved the use of a lead mother as a facilitator and the use of a visual hand called Hanurega Kafi, that's Hausa for immunization hand. And also there was a co-created song that they were using within this group to convey health related messages. The second intervention is the social network for psychosocial support. This intervention aimed to promote engagement amongst caregivers within set groups. It also encouraged them to support each other and just ensure that they attended their immunization appointments when due. The third intervention is the economic empowerment intervention, which involved implementing a microloan to initiate new businesses or boost existing businesses for women within this group. There was also a financial literacy training that was provided to these women in addition to business guidance, just to empower them for successful entrepreneurship. So the Hanurega Cafe is what we see to the right. I'll just speak to it a little. This tool is a visual IEC material that was used, that was designed to facilitate discussion around immunization and also to serve as a passive prompt for beneficiaries to seek RI service. What this means is every woman that was enrolled on this project got a hand tool and it was customized for her. So she would use it to track the immunization visits for her child. Like we see on the front of the hand, we are removable stickers. So once a child immunization once a child has received a specific vaccine or gone to the facility for that appointment, the sticker is removed. And then what you see behind the red is a tick, just indicating how much more vaccinations a child needs to go to the facility for. So on this hand, we see we have 1, 2, 3 on the fingertips, and we have 1 on the wrist. So that depicts the 6 vaccination visits. We also have information on the child development stages and also nutritional needs at the different times for the visits. And we just see a picture in the middle that shows an overall healthy and healthy mother and healthy child. On the next slide, the implementation of the routine body system yielded very valuable insights as well as positive outcomes. We learned that sustained psychosocial support and practical peer-led knowledge sharing can can be a game changer in nudging and motivating caregivers to get vaccinated. We also learned that while a one-time message can nudge initial behavior, there is a need to reinforce messages just so that we're yielding sustained improvements. And we learned as well that sociocultural and religious factors are key criteria for intervention design. If strategies are co-created and with community people as well as tailored to meet their needs, then we're much more likely to have successful outcomes. To the right, we see two charts that show some notable outcomes from the study. A total of 760 participants were tested on their knowledge of immunization at both baseline and endline, and their scores were analyzed just to compare the difference between the study groups. On the top of the chart, we can see that participants in the knowledge sharing and economic empowerment group had the highest mean score at endline, followed by participants in knowledge sharing groups. Participants in the control group had the lowest mean score. Excuse me. And this indicates that the knowledge sharing intervention was effective in improving immunization knowledge. We also assessed immunization status of age-appropriate immunizations by study group, and we observed a positive shift like we see on the charts to the bottom for the intervention groups. That's the knowledge sharing and economic empowerment group, as well as the knowledge sharing group only. For the control group though, we see a drop in immunization status at endline, so it's at a -12. This also highlights the effectiveness of the intervention in improving vaccination uptake. On the next slide, we speak about the CROWN project. That's the Community Reorientation Women Network Strategy that emerged from just a merge of the strengths and lessons from various other similar strategies. This initiative is supported by Aliko Dangote Foundation, and is being implemented by Solina Center for International Development and Research. CROWN establishes a self-sustaining network of women who are primarily polio supervisors, but then there are other community volunteers, and what they do is that they offer home-based counseling and referral support to women in their localities or to households in their localities. It is a community-driven solution, and it's just aimed at improving health, education, as well as livelihood indices. But currently, it is being adapted for zero-dose reduction in three states. That's Bauchi, Kano, and Sokoto, and that's what we see on the scope of the implementation on the top right of the slide. The strategy involves identifying and enrolling volunteers, and so they're trained to conduct enumeration and to provide intervention to caregivers and households. For the enumeration, they'll do a house-to-house walkthrough, collect information on the biodata of a child under 5, of children under 5, women of childbearing age, immunization status of these children, their nutritional status as well. Another thing that they do is that they counsel. So they engage caregivers to discuss key messages on the importance of immunization, the routes, the schedules, the session days, and any other emerging hesitancy issue. So whether a mother has an issue about AAFI, or just any fears she has about vaccination, or hindrances she has from decision makers in the home, so they're able to address it at a household level. They then refer. So under-vaccinated children or children that are seen to be malnourished are then given referral cards for the mother to take them to the nearby PHCs. And then lastly, they track and follow up. And why they do this is just to ensure that the child has received the due vaccines as discussed during the last visit, and also just to nudge the caregivers to attend subsequent appointments. And that is what we're showing, that's what we're depicting on the schema on this slide. Some lessons and successes have been recorded on the project. We see the key lesson is the importance of house-to-house enumeration. This method has paved a way to validate accuracy and reliability of target population used for microplanning. Another key success is the establishment of volunteer network, because through this network, we've been able to leverage and recognize the efforts of women in improving community trust for vaccination, as well as encouraging health-seeking behavior. Lastly, the strategy provided targeted fit-for-purpose approach of reaching 0 dose and unimmunized children across pilot communities. And we know that by tailoring these approaches to the specific needs of all of the different communities, we would see improved outcomes. And that is what we're also seeing. That's what we've seen on the PRAM project. We've been able to make good progress in improving vaccination rates. So yeah, I'll pause here, and we will break into the panel session to discuss some more demand generation strategies and sustainability costs. Over from me. Thank you.
Wonderful. Thank you so much, Sophia and Dr. Layden, for your excellent presentations. From what you shared so far, we've really seen how pivotal demand generation is to achieving health goals. So my name is Liz Colway, and I serve as Director of Boost Community Engagement and Applied Learning at the Sabin Vaccine Institute. I'll be leading the next section of this webinar, which is the panel discussion. So first, I'll ask our panelists a few questions, and then we'll open it up to the audience for questions or comments. So please do continue sharing your questions and comments in the chat. I kindly ask all of our panelists to keep their responses brief, as we'd like to have some time to address as many questions as we can. So besides Dr. Layden, who you've already heard from, we're also joined by Alhaji Ahmed Aya, who's the head of community engagement and polio eradication at the Aliko Dangote Foundation. He has several years of experience in polio and immunization projects, and has been at the forefront of conceptualizing and reimagining demand generation interventions for immunization, nutrition, and health at large. We're also joined by Lillian Mutua, who's the head of health promotion for Nairobi City County. She's a dedicated health promotion and education specialist with over 8 years of experience as a registered nurse and 33 years of experience as a health program manager. So with that, welcome everyone. My first question is for Alhaji. So drawing on your experience as a pioneer of various demand generation interventions, how is the Crown an improvement on preceding strategies like the name-based strategy and RIBS? So over to you.
Yeah, thank you very much. And thank you very much, Liz. And thank you very much for all the speakers, and particularly the Sophia, who has dwelled much into talking about how the Crown was conceived and is now working on. So your question is like, for example, if you look at what the Crown has tried to do at the moment is to look at what have we done previously that was not working, and what can we do better now so that it will now become something that is more sustainable. If you listen to Dr. Ladan's presentation, almost all the interventions of demand generations are being created by partners in order to achieve certain goals during the period of their program. So when they are there, those kind of programs dies with the project. Sometimes you find out that these projects are being designed for a specific region, doesn't literally replicatable in most of the regions. So we came in with the Crown, that is the Community Reorientation Women Network, as a result of looking at what is exactly we want to bring onto the table. Who is our target? Who will talk to this target in a more sustainable manner? And how can we make it more actively done? And what are the lessons that we learned from other global communities where they have successfully implemented demand generation and it has been sustainable, like the ones that they have mentioned in Indonesia, in Ethiopia, and other places. So it's all, you can see they are all women driven. And these women are living within the community. So what do we try to do differently here? We look at it, what are the resources that we have on ground that have some basic knowledge of health intervention? If you look at polio, decades of activities in Nigeria provided an opportunity for these women to learn a lot. They've been trained by WHO on every round after round for interpersonal skills, getting into the homes. They have developed the skills to talk to the women on how to resolve non-compliance. Even the women don't want their children to be immunized. But the saddest part of it, when they get home to these families, they are asked questions that they have no answers, because the family sees them as health workers, because this is the only government health intervention that is already at their doorstep. So when these women get into the communities, whether it is in the rural areas, semi-urban, there are women engage them. And I took time to ask people, what are you doing in these homes? What are the questions that these women keep asking you? We realize that they're asking them huge and tons of questions that they have no answer, because they are being regarded as health workers. And guess what? Whatever advice they give to these women, the women take it all out. If they tell them don't go to the hospital, they don't go. If they tell them, in fact, surprisingly, they even talk to them about their social interests in the home, assuming that these women knows about it. So we now look at it, okay, if you have this over thousands and thousands of women in the field who has already been trained to do some work, why don't we build their capacity? The idea is, even if they do not do anything in the community, you are building over thousands and thousands of mothers to be tomorrow. So you are now reducing the huge gap between the system and the information that's supposed to be. However, when there was an interruption of WPV in Nigeria, the number of rounds upon rounds have reduced. So we start to ask the women, what are you doing? They're still engaged with those women in the communities, because they have become social friends. Even they're from distance. If there are marriages, there are naming ceremonies, they've all been invited. So we feel that this is a very good tool that we can use to build their capacity, not only on the health intervention, but all other things. And we also realize that how can we compensate them? Because now polio is paying them to do the work that they do within a short period of time. So we now build them under this kind of financial inclusion. We build the capacity of knowing what to do. How do you make your business? How do you run your business? But one thing that we found very key and is very interesting about the women is when they learn how to do this kind of nutrition intervention, when they can be able to do some kind of a powder for the women, or they call them Tom Brown in Nigeria, it becomes very, very, very much opening for them. They were able to support the parents. And when the parents have seen that whether a breastfeeding mother or a child that is to be weaned, or the child that is already looking hunger on a sign of malnutrition, when they treat these women became the mothers of the communities. So we realize that this is very, very important. Then we now say, okay, you cannot deal with what you don't know. So that's why identify, enumerate, and refer them for vaccination. So this is what we are currently doing, and it is now yielding a maximum result that we expected. However, when we look at it, can we drive it ourselves, or what can we do to drive it? When we now educate the health workers, whether you're on the nutrition piece or you're looking at immunization or antenatal, everybody realizes that this is a solution to their problem. So now it is those health workers that feel that they want to introduce those things in the community, so that these women will be able to help them to do that mobilization. But one thing that we realize that, again, we try to use to solve the barrier is between the husband and the wife. So what we do whenever there is an enumeration, these women, we identify those that are needed for support. We now organize also the men to the traditional leaders, so that they will be counseled, they will be told about the children, they'll be told about the pregnant mother. So when the husband comes back home, you can see the conversation between the mother and the child, and between the husband and the child. So you can see it makes a lot much easier for us to drive. So we are learning from other lessons of other jurisdictions, but we feel that we now got the right model that we can expand to many places. And why did Aliko Dangote Foundation pick it up to say, look, we want to support it? Because this is an indigenous organization, it's a philanthropy organization that is based in Nigeria, that is supporting. So now Crown is not only working in Nigeria, it's also in Chad and in Yemen, in Niamey. Thank you.
Wonderful. Thank you so much for sharing your insights with us. My next question is for Dr. Layden. Could you shed some light on the strategies that the National Primary Healthcare Development Agency is considering to optimize its demand generation strategies? Over to you.
Okay, thank you very much, Liz, for this very important question. So I think MPSCD has just recently came up with new strategic blueprint and initiative under the present AD and the coordinating Minister of Health and Social Welfare. There are three pillars that these key strategies and initiatives were categorized. And pillar one is to strengthen MPSCD position for implementation of the sector-wide approach and the National Health Act. So a demand generation initiative under this pillar is the implementation of a comprehensive communication strategy as a vehicle to drive the implementation and monitoring of strategic PHC services in line with the sector-wide approach. And the second initiative under this pillar is a robust citizen mechanism and feedback system for our services. A lot of services has been offered at the PHC level, at the lower community, but there is no avenue for citizens to express their concerns or to express their satisfaction about these services being offered. So we are working in that direction to come up with a digitalized system of efficient two-way feedback mechanism between the citizens at the community level and also the health system. For pillar two, there are key demand generation initiative under pillar two of MPSCD new blueprint and initiative. And pillar two is all about efficient, equitable, and quality, trusted primary healthcare services. And this key demand generation initiative under this pillar is to design and implement a comprehensive community health workforce model for demand generation and community-based service delivery, and also to review and implement a comprehensive PHC demand generation strategy in collaboration with all stakeholders. Just recently, Sophia and Alhaji elaborate extensively on the body and crown, initiative. And there's also the name-based community engagement strategy. A lot of strategies have been put in place. Some are yielding result and some are not yielding the result that we so much desire. So reviewing and to review most of this strategy that we put in place over the years is also one of the key focus of MPSCD, so that we can know where things are working very well and where things are not working, so that we can also make adjustment for improvement. There is also an effort, which is one of the important initiatives under pillar two, which is to develop a holistic advocacy and communication strategy. Then the third pillar, which is about, there is also a very important initiative under that one, which is to reorganize polio campaign strategy to improve its effectiveness and also interrupt the transmission of the circulating variant polio virus, which is CBB type 2, that is currently ravaging some section of the state of northern Nigeria. Implementation of this key initiative and strategy will be done in a coordinated manner at both national and subnational level. One of the key challenges that we are having at MPSCD and in the program is fragmentation in the implementation of demand generation activities. Demand generation activities is not implemented in a coordinated manner at both national and subnational level. So we are trying to reactivate a robust structure at the national level and also replicate that same model at the state level, which will provide central ACSM support to all programs like routine immunization, zero dose reduction, new vaccine introduction, programs like polio eradication, programs like non-polio supplemental immunization activities, reproductive maternal and newborn child health, as well as outbreak response. So recently we are seeing outbreak of cerebrospinal meningitis in Jigawa State. So we are working in a coordinated manner to implement demand generation activities that will lead to even curtailing future outbreaks before they occur. And the other important objective is to build, to improve coordination and support. Lack of coordination is one of the key challenges that we are seeing in the implementation of demand generation activities at board level. So coordination will be improved with these robust structures in place. Then to also build capacity in key program areas. The key strategic approach for implementation of these key initiatives usually entails advocacy and stakeholders engagement. We're also looking at implementation of holistic community engagement strategy that will also entails implementation of human-centered design approach, where citizens or communities will be given opportunity to participate and also identify solutions to some of these barriers that are leading to poor immunization and PHC uptake in the community.
Thank you so much, Dr. Layden. Apologies for interrupting. Thank you so much. Okay. And just want to have time to get to all of our panelists, but we will definitely circle back to you. Appreciate your insights and elaboration on those strategies. So moving on to Lillian, if you could share what the demand generation strategies that have been implemented in Kenya are, including maybe some of those key success factors, and if you found any similarities between those strategies, the ones that you're using, and what you've heard today. So over to you, Lillian. And I think, Lillian, if you're talking, you're on mute right now.
Sorry. Good morning, good afternoon, good evening from wherever you are joining from. This is Lillian Mutua from Nairobi, Kenya. I head the Health Promotion Department in Nairobi City County. Yes, we have similarities with what have been discussed, especially when it comes to the community health volunteers. We are not maybe giving them some money to generate into their businesses. However, we are able to give them a stipend that is being paid by the county government, just something to keep them going, and also to ensure that they are enrolled for medical cover. That is the NHIF, which is a National Health Insurance Fund, and they are able to get medical services. The other people we have brought on board is the National Government Administrative Officers. These are people who work for these are officers who work for the government and have authority at both the national, the sub-national, the district, the location up to the ward level. So we have brought them on board, especially to ensure that they help us negotiate with any defaulter on the ground, because they stand authority, so that if we have a defaulter or someone who is not allowing their child to be vaccinated, then this can be taken up as a government matter, because we know it's the child's rights to get immunization. The father or the mother or the guardian has a choice, but it's also the responsibility of the government to have all their children vaccinated. We also are working very closely with the religious leaders because we know that religious leaders are held in trust by their congregation, and they are also decision maker for a bigger or larger community. So we bring them on board and make sure that they are part of our demand creation team. And we use their platform in the churches, in the mosques, in the temples, in whatever congregations that they use, so that we are able to reach the congregants and their children. So there's a lot of similarity in this, but I'm just wondering if the monies that are being pumped into the businesses of the women who are the mobilizers or the team for the demand creation, we should also be thinking about sustainability and ownership. I've seen programs which are led by partners in various health fields. Once the partner withdraws or the programs comes to a halt, then continuity becomes a problem. So we need also to think about involvement of the community so that they can own the process, and they can also look at sustainable sources within their own communities with the resources that are available. So for us, we are thinking about bringing on board the young women who have not yet even delivered, to start educating them on the benefits and the importance of immunization and why a child needs to finish their scheduled vaccination. And we are also talking about the life course immunization. So we are visiting different target groups, either within the religious institutions, at workplaces and social places, to make the immunization agenda a social conversation, other than it being looked at as a government directive or a process by the government. And this is from lessons learned, what we saw during the COVID-19 vaccination, the statements that were given by the government. We know that in the first year, the frontliners and the first groups that were being given the vaccine, it came in very handy. But then come to 2022, up to now, we have been having a challenge because people now start having infodemic, misinformation running on social platforms, the discussions in the communities just because they were not involved. So there's a lot to be learned in the immunization space, and also from other successful programs that have happened within the health space and also in the social spaces for any health campaign. We have seen, we are also still learning from the successes of the HIV program, the successes of the TB program, and right now also from the adolescents sexual reproductive health programs. So we look at all programs widely and think of what is it that we can borrow that have made other programs successful. So for me, demand creation is very important because we need to look at the demand generation strategies for us to address the supply. We need to categorically look at who are our primary audience, who are our secondary audience, who are our tertiary audience. Why we do this is because we have the primary audience, who is the person who is responsible for the child, or the person who needs to be getting the vaccine, or who needs to get the any other service. Then we have the person who supports them. For example, if it is a child who has two parents, maybe the mother is the one to take the child to the facility for vaccination, but does the father equally have the same understanding about the importance and the benefits of this vaccination? So we need to look at the three-prong, that is from the first primary audience, the secondary, and the tertiary, so that cumulatively, if it is at household, when we look at our settings as Africans and our culture, you will find that the grandmother in the household, or the older women who are the in-laws, they also have a say to what will be done to the child. The elders in that family also have a say. So it is more of a communal social responsibility. So we must bring a collective approach into immunization for it to be a success.
Great.
In the
Thank you so much.
urban settings, we also need to understand that people are privy to the social media. They also research, they also read articles far and wide, and they have their own set mentality about benefits and importance of immunization. Thank you so much.
Thank you so much, Lillian, for your intervention. And very much appreciate everyone sharing your questions and comments in the chat. I know we only have a few minutes to go, so we'll definitely try to answer them directly in the chat. So I encourage our panelists to take a look at them. I did want to ask a question to Alhaji. Given the issues around funding for demand generation interventions, and Lillian kind of alluded to sustainability there, could you share if there is a sustainability plan for Crown?
very interesting. And you know, for example, when I mentioned to you that we learn from the mistakes of others. So first of all, we ask women to come voluntarily. So what we do is to encourage them to form like a small cooperative of their own daily savings. And then whatever intervention that is coming, it should be as a seed capital so that they can sit down and borrow. I tell you, surprisingly, when we started this, in a community of women, they have raised huge amount of money, and they are now reinvesting those money that they are into other productive activities. So they are coming because they are coming for the savings, and they're coming for the activity that they are doing. And their capacity is being built on many fronts of how to do many small businesses. And then we even taught them how to manage loans as they receive it. So we're not giving any stipends, we're not collecting anything from anybody, but they are expected to generate their own income and continue sustaining what they are doing. What is the key message here? Many people see them as what they are doing and find it very interesting to support them in different ways. When we wanted to do some demonstration of nutrition in a community, you find that one philanthropist will say, look, I'll provide the commodities so that when you do it, you now distribute it to the needy in the community. So it is a self-propelling kind of a system. So the sustainability is within the system. So we created them under cooperatives, and then they borrow from the cooperative, and they take loan, and they guarantee among themselves. In fact, when we have a box of keeping, 3 people hold the keys of the box, and they all come with their savings books. They collect, and then they loan to people. And they even graduated from lending money. They even have some house commodities of food and items that they contribute among themselves. So it is self-sustaining on their own. In fact, all the places where we have launched it, we don't have to go back again to tell them what to do, because they have now been learning through their processes of what they are doing. So we are not paying them any stipends. They are not under any government. The fear of under government, if any government feel that these people are too influential, they are much more in the community, they can do much things, they can tell people about what is happening about the life in their community. So these politicians may be able to undermine them. So we give them that kind of independence. And this independence comes from their own selection within their own community. And they are not going to work in more than 50 households, and they work at their own time. There is no specific time for you to work. At your pleasure, at your lifetime, that's how then you organize your meeting on your own, because the women knows what is the best time to come and talk to each other. Over.
Thank you so much for sharing your thoughts on that. And I know we're just about at time, so I want to go ahead and just thank all of our panelists and speakers for today's presentations. Really appreciate your insights, and thank you to our participants for sharing your thoughts and questions. We'll of course continue the conversation in the Bright Spots Learning Group on the Boost platform, so feel free to follow up there. Like Aisha said, we'll also be sharing out the recording of today's session and slides as well, so you will have copies of that soon. I'm going to go ahead and turn things back over to Aisha in case she has any other closing comments, and just thank everyone again.
Yeah, if we can get that last slide back up. Just again, thank you to our moderator and guest speakers for sharing your insights and lessons learned. Please remember to take the post-session survey, which will pop up on your screen after the close of the session, so we can work to improve our offerings. And a reminder to those that have attended all 3 sessions and completed all post-session surveys, we will award you a certificate of attendance by the end of next week. We hope to reach out soon with future Bright Spots offerings and encourage you all to email info@boostcommunity.org if you'd like to share your own story or lessons learned with the community. Thank you again to all of our speakers and participants for your engagement throughout the whole series, and I hope you all have a wonderful week.
Thank you.
Thank you.
Thank you, everyone.
Thank you,
Thank
everyone.
you.
Thank you, everyone. Thank you, Aisha.
Thank you,
Thank you.
Thank you, everyone.
Fantastic opportunity. Thank you.
Thank you.
Thank you, Alhaji. Thank you, Alhaji. Yeah, this is Dr. Ali Oladan.
Oh, thank you very much, Dr. Ali. It's a pleasure talking to you.
Thank you very much.
Thank you, everybody.